Thank you for joining us on this hearing this morning as we review the value of Medicare Advantage overpayments. We'll commence our hearing in a moment. We're now overpaying Medicare Advantage plans around 13%, and on average, according to MedPAC's latest analysis. In some areas, we're overpaying by 50%. The President just sent us a budget with more than $500 billion in cuts to Medicare over the next decade, but none of those cuts came from Medicare Advantage. The overpayments in that budget remain firmly in place. The President's budget also set to Congress a legislative response to the so-called Medicare trigger. Again, the President's plan protects the special interests of the Medicare Advantage plans and puts all the costs or the cuts of meeting what I think is an irresponsible trigger policy squarely on the backs of America's seniors by increasing prescription drug premiums for millions of beneficiaries. Clearly, the administration believes that these overpayments are warranted. We asked the GAO, the Government Accountability Office, to report back to us regarding to what extent these overpayments translate into reduced cost sharing or extra benefits, and if any, or if so, whether this is an efficient way to achieve any goals that were inherent in these reduced costs or extra benefits. The report was requested jointly by the Committees on Ways and Means, our subcommittee, Energy and Commerce, and the Government Reform and Oversight. I don't want to steal the GAO's thunder, but I think it's worth highlighting a few of the things that the report will discuss today. First, we have no idea what beneficiaries actually receive in Medicare Advantage plans because there's absolutely no requirement that the Medicare Advantage plans turn over any data on the services actually rendered to the government or to beneficiaries. The only way GAO could analyze the different benefits was to rely on projections from the Medicare Advantage plans with respect to how they said they'd spend their subsidies. That's not acceptable. That's that's just like no bid contracts in Iraq. We ought to know what we're getting, and it would be a simple matter for CMS to request that data. Second, if you look at the Medicare Advantage plan's own projections, the GAO finds that beneficiaries can spend more in a Medicare Advantage plan than they would in fee-for-service Medicare. They can spend. They don't necessarily all spend more. The services most often associated with higher co-payments are home health and hospitalizations, two services that are vital to sick people and are obviously more of a burden to low-income people. If plans successfully cherry-pick healthy seniors, which they do, and the payments are based on averages, it means we're overpaying them even more than we think. Third, the report shows that MA plans invest 3% in Part B premium reductions, and that's the only improvement that's guaranteed to be valuable to every enrollee. Fourth, the Medicare Advantage plans are far less efficient than fee-for-service Medicare, which essentially operates with a 98% medical loss ratio. In contrast, the average Medicare Advantage plan, their medical loss ratio is 87%. But nearly one-third of the plans have a medical loss ratio of less than 85%. It would be good to know how low the medical loss ratios actually go. CMS has actually refused to release that data to GAO, and my hope is that they'll be able to explain why they won't release the data and perhaps change their minds. GAO's findings raise serious questions about the value of lavishing subsidies on Medicare Advantage plans as a means to, quote, help Medicare beneficiaries. Today's second panel will reveal what's happening to Medicare beneficiaries in the real world as they attempt to navigate the confusing world of Medicare Advantage and the shoddy sales practices that their shyster-like salespeople foist on frail and often confused Medicare beneficiaries. Our witnesses will confirm that many Medicare beneficiaries are unaware that their costs may be higher than they would in traditional Medicare. They believe that they're enrolling in a Medigap plan under which they'd never pay more, and they're shocked when they learn how much they have to pay. These issues are only a small part of the oversight needed in the Medicare Advantage plans. I'd be remiss not to highlight that the CHAMP Act, which we passed out of the House last year and is still pending in the Senate, addressed many of these concerns. It leveled the playing field on payments to Medicare Advantage plans. It required plans to meet a medical loss ratio of 85% to participate. It ensured that beneficiaries wouldn't pay more in Medicare Advantage than they would in traditional fee-for-service Medicare, and it provided states with the tools they need and the federal government refuses to use to regulate marketing of Medicare Advantage plans to protect consumers. It may sound differently, but I'm not against private plans in Medicare. My district has perhaps the highest penetration of Medicare Advantage in the country. Half of the people in my district, not half of the insured, or half of the people in my district belong to Kaiser Permanente, a credible managed care plan. And they should have the choice to join that. But the rest of us shouldn't be subsidizing the people who choose to go into Kaiser. Plans should compete on a level playing field and preserve many of the core choices that really matter to beneficiaries. I think that managed care and multidiscipline group practice will be the medical delivery plans of the future, but I see no reason that they have to be grossly overpaid and underregulated. Mr. Camp?
Well, thank you, Mr. Chairman. And what are the benefits of Medicare Advantage plans and what they provide to beneficiaries is an important question. So thank you for having this hearing. It really goes to the heart of the debate about Medicare Advantage. Unfortunately, most of the witnesses today are going to use the highly selective data and hypothetical scenarios to draw negative conclusions about the benefits provided by Medicare Advantage plans. This stilted analysis does not reflect the experience of most Medicare Advantage enrollees or the actual value of the plans they provide. Medicare Advantage plans provide significant savings for their enrollees compared to what is charged in traditional Medicare. According to the GAO, beneficiaries in Medicare Advantage would expect to pay $804 less this year in out-of-pocket expenses than those in traditional Medicare. And these findings were echoed in a recent Kaiser Family Foundation report that examined actual beneficiary health spending. The Kaiser report found that on average, beneficiaries enrolled in Medicare Advantage coordinated care plans would save nearly $550, and beneficiaries who used the most health care services would save nearly $4,200 compared to those in fee-for-service Medicare. Anyone who doubts that Medicare Advantage plans provide real savings to beneficiaries need only look at the rapid growth in enrollment in these plans. If beneficiaries did not see the real value in these plans, enrollment in Medicare Advantage would not have doubled since 2003, bringing total enrollment in these plans to nearly 9 million beneficiaries. Fee-for-service Medicare fails to protect beneficiaries from catastrophic health care costs and often forces them to pay large deductibles and cost-sharing payments. This reality is the reason why approximately 40% of Medicare beneficiaries have either enrolled in Medicare Advantage or have otherwise purchased Medigap plans. Instead of attacking programs that provide choices and quality care, we should be looking at ways to reform traditional Medicare, the traditional Medicare program, which provides less. This is exactly what the Republican majority did when it created Medicare Advantage in 2003. I am disappointed by the analysis in GAO's report, which fails to reflect the real-world experience of the beneficiaries enrolled in Medicare Advantage. In fact, GAO's report does not reflect the reality of a single beneficiary in any Medicare Advantage plan. The report only looks at hypothetical beneficiaries who use only certain types of services and enroll in a narrow selection of plans. I frankly expected more from the GAO. At the conclusion of this hearing, I intend to send a letter to the Comptroller General asking that GAO undertake a new study. I hope this study will review the actual services used by real beneficiaries and compare that to the benefit packages of the most popular Medicare Advantage plans. I suspect that this analysis will give a much fairer and more representative view of the savings that Medicare Advantage plans provide to Medicare beneficiaries. Critics of the program will undoubtedly use this report to attack Medicare Advantage and assert that it fails to provide real benefits to program enrollees. In doing so, they will ignore the reality that the vast majority of plans actually provide much better cost-sharing benefits. They will also ignore the fact that GAO found that 500,000 beneficiaries have chosen to enroll in plans that have no cost sharing on inpatient hospital visits. Some opponents of seniors being able to choose their health care instead of government believe that seniors are not smart enough to make choices about their health care. I fundamentally disagree, as do the 18 million seniors who've chosen Medicare Advantage and Medigap plans, as I said, more than 40% of all Medicare beneficiaries. If we give them the opportunity, seniors will choose the plan that best fits their needs and provides them with the best benefits. And if we are really concerned about seniors not getting access to the best possible cost-sharing protections, perhaps we can agree to improve the comparative data that we provide to all Medicare beneficiaries. If everyone in Medicare Advantage could see how much they could save by enrolling in Medicare, everyone in Medicare could see how much they could save by enrolling in Medicare Advantage, I believe that even more beneficiaries would enroll in this important program. Thank you, and I yield back the rest of my time.
As between bureaucracies and my friend would yield, I would like a report also about what beneficiaries receive, not what they're offered, and have asked CMS repeatedly to give us that information. They contend they don't have it, and they don't collect it. The GAO would love to do the report for us, and the data doesn't exist. So I would be delighted to join with my colleague to say, look, let's require this data, and I'm not sure whether who would be able to better use it for their position, but the fact that we're not getting the data, I think, is that we're kind of legislating in the blind, and I hope you agree that we can require that data to be forthcoming, and it can be sanitized so we protect competitive advantage and that sort of thing.
I think being able to use real data from real plans and not hypothetical plans, this report purports to be an analysis of cost sharing in Medicare Advantage, and it does nothing of the kind.
This is real projections from each plan.
But let us hear from the people who have been wrestling with this, and we'll start with Carrie Weems. Administrator Weems is the acting administrator for the Center for Medicare and Medicaid Services, affectionately known as CMS, from the U.S. Department of Health and Human Services. Why don't you proceed to enlighten us, Mr. Weems, in any way you'd like.
Thank you. Good morning, Mr. Chairman, Mr. Camp, members of the committee. Mr. Stark, you said you'd be delighted, so let me add to your delight today. I have directed our Centers for Beneficiary Services, Beneficiary Choices, to begin collecting the data that you request on additional benefits. We will collect it for past benefit years. You know, there will probably be some data analysis that we'll have to do, but going forward, we will collect the data in a regularized format so that we can all understand it. I agree with the chairman and with the ranking member. Let's have a discussion about the facts. and let's get the facts on the table. It's time to do that. I hope to be able to provide that information to this committee, to the GAO, and to others, again, respecting proprietary information. Medicare Advantage is providing an affordable, high-value choice to roughly 9 million beneficiaries. In 2008, plans offer an average of over 1,100 additional value to enrollees beyond original Medicare. For example, plans offer such benefits as routine eye care, hearing exams, additional inpatient hospital days, reduced cost sharing for many services, and unlike original Medicare, MA enrollees do not face separate cost sharing for physician and ancillary services when hospitalized. I'd like to now discuss GAO's findings in their report released today and focus on one important Medicare benefit, inpatient hospital stays. At the risk of having warring charts, I did bring some charts with me today, and I would ask the committee's indulgence as I discuss them. If we would first turn to the one to my right, your left. This is a complex chart, but I think
Kerry, do we have a... Okay.
I'm hopeful that you do, sir.
Thank you.
Let's start with the first column that says 1 day, and then we'll focus on... For a 1-day hospital stay, for a Medicare Advantage plan... I'm sorry, do we all have it? Do we have enough to go around? Thank you. For a 1-day hospital stay, the average cost sharing for a Medicare Advantage enrollee is $237 as opposed to $1,108 under a regular fee-for-service Medicare. And then if you take that and weight it by population, for a 1-day stay, it's $225 as opposed to the $1,108. And then we show the various plans at various percentiles, the 25th percentile, the median, the 95th percentile. Even at the 95th percentile for a 1-day stay, you can see that the cost sharing is considerably less than what it is for fee-for-service Medicare. And in fact, if you now turn to the green boxes at the lower, you have to get to the 98th percentile of Medicare Advantage plans, and still there's lower cost sharing. And the lower cost sharing there is $952. Then weight that by enrollment, and that's the very last row. 99% of beneficiaries have chosen an insurance product where their inpatient hospital copay for a 1-day stay is less than fee-for-service Medicare. And in fact, now taking that bottom row, you can look across and see how beneficiaries have chosen through this choice to protect themselves against catastrophic or very high cost sharing that you can see in fee-for-service. So take, pretty close to the average. The average inpatient hospital stay is about 5.5 days. So at 6 days, the expected Medicare cost would be about $1,400. 87.5% of Medicare beneficiaries enrolled in a Medicare Advantage plan have chosen a plan which protects them against those higher costs. And then you can see how that plays out even on very long outliers. And this is weighted by the actual choices that beneficiaries pay. This chart to my left, the bar chart, shows essentially the same data, but it's unweighted by beneficiary. The most telling piece, just for this one benefit, is the choices that beneficiaries have exercised to protect themselves against very high out-of-pocket costs. So I think that lays a good foundation for our discussion today. I'll stop there and
Okay, we can continue this in our inquiry, and I would now turn to James Cosgrove as the Acting Director of Healthcare Issues. Do you direct the issues or the department that, that looks at the issues at the GAO? And I guess you have to suffer as the author of this, right?
I am the director on this report. I wouldn't say I suffered. I think team worked long hours to put
All
it
right.
together, so maybe they suffered.
Well, why don't you expand on the report, which we've all had a chance to at least see a summary of, and tell us what, enlighten us in any manner you choose.
Okay. Thank you, Mr. Chairman, and Ranking Member Camp, and members of the subcommittee. I am pleased to be here today to discuss our findings on cost sharing and additional benefits in Medicare Advantage. In 2006, Medicare paid $59 billion to plans, which was an estimated $7.1 billion more than would have been spent if plan enrollees had instead received care through the fee-for-service program. So an important question is, what do beneficiaries and taxpayers get for this additional spending? Our report and my testimony today attempts to shed some light on this issue. Our findings largely pertain to the rebates that plans received. As you know, plans submit bids for providing Medicare-covered services. Plans that bid less than established amounts receive rebates up to 75% of the difference. And plans must use those rebates to reduce cost sharing, reduce premiums, or add benefits. Because the benchmarks are set relatively high, plans may submit bids that exceed fee-for-service spending and still receive substantial rebates. Plans may also charge beneficiaries a premium and use that money to reduce cost sharing or add benefits. In our report being released today, we analyzed how plans projected they would spend the rebates and premiums they received in 2007. As has already been discussed this morning, these are plan projections because the data currently do not exist to know how plans actually spent the money or the services that they actually provided. Nearly all the plans in our study received a rebate, which averaged $87 per member per month. And on average, plans projected allocating their rebates as follows: 69% to reduce beneficiary cost sharing, 20% to reduce premiums, and 11% to add some coverage for benefits that are not provided under traditional fee-for-service. For example, plans projected spending about $4 per member per month on some dental care. Plans projected spending lesser amounts on other types, such as vision care or health education. Because Medicare pays significantly more for Medicare Advantage beneficiaries, and plans project using much of that additional money to reduce cost sharing, it's no surprise that on average, plans' overall expected cost sharing is relatively low. However, we found that beneficiaries in some plans could pay much more for certain important services than they would have paid if they had remained in fee-for-service. And this is because plans are allowed, within limits set by CMS, to establish their own cost-sharing requirements. So, for example, about 19% of Medicare Advantage enrollees were in plans that required cost-sharing for home health services. In contrast, beneficiaries in the traditional fee-for-service program pay nothing for that care. We also found that beneficiaries in some plans could face expensive cost sharing for inpatient services, depending on how long they were hospitalized. So, for example, as our chart shows, some plans charge $275 or more for the first 10 days of care. This is an example of one plan, but there were 15 or 16 other plans like it. In fact, there were 80 plans that charged more than $200 a day, some as much as $375 a day, some charged for more than 10 days of care. Of the 80 plans, they enrolled 500,000 beneficiaries. Many of these plans had maximum out-of-pocket limits, but many of these plans also had maximums that excluded certain services. As our chart also shows, and as Mr. Weems has pointed out, beneficiaries in those same plans might pay relatively less for either short hospital stays or extremely long ones. Nearly half the plans we reviewed projecting using some of their rebates to limit beneficiaries' annual out-of-pocket spending for cost sharing. But as I just mentioned, many plans excluded certain services from those maximums. For example, physician specialists, mental health care, outpatient substance abuse treatment, home health services, prosthetics, and durable medical equipment. So in closing, it's important to remember that there is no free lunch when it comes to Medicare Advantage. Any reductions in cost sharing or premiums and any increases in benefits have largely been made possible only through the infusion of billions of extra dollars into the Medicare Advantage program. These extra dollars have resulted in a greater burden on taxpayers and higher Part B premiums for all beneficiaries, including those in the fee-for-service program. And in spite of these extra dollars, some beneficiaries may face higher cost sharing for important services. So as Congress considers the design and the cost of the Medicare Advantage program, it's important to remember to balance the needs of all beneficiaries and ensure the program is sustainable. So, Mr. Chairman, this concludes my prepared remarks. I'm certainly happy to respond to any questions that you or other members might have.
Thank you. Is it your feeling, Mr. Cosgrove, that if we required data from the plans, obviously retroactively, as to what they actually provided, and I guess I'd like to make this distinction, Mr. Weems and Mr. Cosgrove, a benefit offered is a different cat than a benefit used. Is that a fair? In other words, take a look at me, and you could offer me a lifetime membership in a weightlifting club, and I'm not as valuable as that might be to my young, vigorous ranking member. It would be absolutely useless to me. And so while it has a value if I used it, now if I could sell it to somebody, but if you offer, I was looking at the dental benefit, for example, $4 a month. That's less than $50 a year. Now, I don't think you can get your teeth cleaned for $50 anyplace. So I recall it's maybe $100 and change, as I think. So, I mean, I think that if we had some figures as to what was actually spent and used by our beneficiaries, we'd have a better ability to assess the value of these plans. Is that?
Absolutely. We have no information on utilization. I want to point out that the dental benefit, the $4 per member per month, was on average the most expensive additional benefit that plans offered. And $1 of that $4 is actually paid by beneficiaries through additional premiums.
And also, we skipped over here, but according to your full report, a third of the private fee-for-service plans, and there are, I'm sure our guests will learn that there are kind of two plans, I think, or two types of plans, charge more for home health care than standalone fee-for-service Medicare. If they offer an out-of-pocket cap, they often exclude things like mental health, home health care, the most valued for very sick people and probably the most expensive for them to provide. Is that a fair assessment of?
Overall, roughly half of beneficiaries are in plans that have a cap, but half of those are in plans that have a cap that excludes something. And home health is frequently one of the services that are excluded, yes.
And we're talking generally across the spectrum about a medical loss ratio of 85%, some perhaps a little higher, a third of them plans, or 30% of the plans lower.
That's right.
And just for the record, what that means is that 85% of what the plans take in premiums or subsidies or government payments, whatever, 85, for every dollar they spend 85 cents on medical care, and the other 15 cents can be most anything.
Well, the other 15 cents is going to administrative expenses and profit.
Okay, and if you compare that with Medicare, our medical loss ratio there is north of 95%, probably 97, 98%. Is that fair, Mr. Weems?
According to the trustees' report, it's approximately 98%.
So what we're saying is for every buck the taxpayers and the beneficiaries pay into Medicare, they're getting 97 or 8 cents worth of medical medical care, and I think that's important to compare. And I know, Mr. Weems, you've suggested that in these services offered, and again, I don't want to beat this dead horse, but when you say that 2/3 of the plans have coverage for eyeglasses, you don't mean that they get a pair of eyeglasses every year.
No,
All right. And they're often a limited dollar amount.
typically.
Yeah. And so that, I mean, for any of my colleagues who, as I do, have Blue Cross, and they give you a list of places where you think you could get eyeglasses for $50, guess again. I mean, maybe $500 unless you go to Walmart or Costco. But we don't have, I think, and I think we'll hear from witnesses later, either defined benefits and or marketing restrictions that would prevail in most states. We have pretty defined benefits under the old Medigap rules. Is that, I mean, what are there, 11 plans?
Right.
Okay. And when we wrote that bill, I think we had pretty much agreement among all the insurers who were writing Medigap at the time, including AARP and whoever else was in the business, that with those 11 plans that gave them enough leeway to provide a variety of coverage for people to choose from. Why wouldn't something similar to that be useful to the beneficiaries in Medicare Advantage? Let's say that we said, look, let's design, if you've got how many 1,000 plans here, let's design a set of benefits within which these parameters, they could operate and compete, come back to you or to us for additional benefits if necessary. But why wouldn't that simplify your lives for keeping track of it, ours for understanding what the beneficiaries are entitled to? Do you have an objection to that, Mr. Weems?
Mr. Chairman, at its heart, the Medicare Advantage program is about choice. And restrictions on the benefits would limit those choices. And I think we should be in a position of giving our beneficiaries a large number of choices. One of the things that we have done is to move to make sure that those choices are more understandable and presented to beneficiaries in a more standardized fashion.
But you don't think they should be limited in number?
No, sir.
Okay. Well, then in Part D, you'd suggest that anybody signing up for a Part D drug plan should be able to buy any drug they want.
Well, we not any drug. We want to make sure that they are FDA approved.
Okay, I'll spot you that one. What's next?
Well, and then we allow plans to provide choices through various formularies.
But you allow them to limit my choice, don't you?
The same way that Medicare Advantage plans allow a range of choices through different benefit arrangements.
Okay.
Yes, sir.
Mr. Camp?
Thank you. Mr. Cosgrove, let me first begin by saying I appreciate the GAO staff briefing the minority staff earlier in the week on this report. I'm disappointed we couldn't get the full report before today's hearing, yet apparently the New York Times did not have this problem, as there's a story in today's paper quoting from the report. So they had things that the minority staff didn't have. If we're going to have a meaningful discussion, I think we do need full information. I see. Now, just let me move on to the thrust of the report as I understand it in this short time frame. I'm concerned that your report isn't an actual representation of beneficiaries enrolled in Medicare Advantage plans, but instead, again, this hypothetical scenario for beneficiaries using a single type of service for a small subset of plans. So let me ask you, in your testimony, you included a chart that showed how Medicare beneficiaries could pay more for inpatient services. Is it true that this just reflects one plan out of over 2,000?
No, it's a representative plan out of 80 plans that we found.
I believe it's a representative of one plan out of over 2,000 plans beneficiaries have choices of. Let me ask you again, is it true that 84% of beneficiaries are enrolled in plans where they could pay less cost sharing for inpatient services than in traditional fee-for-service?
Well, as we point out in the report,
I believe the answer is yes to that, and I guess I would prefer just a simple answer there. I'm correct, am I not?
yes.
Is it also true that over 500,000 beneficiaries are enrolled in plans that charge no cost sharing for inpatient hospital stays?
Yes, that's in our report.
I think it's important to understand that many beneficiaries who are buying insurance are buying protection against catastrophic events, even if they don't use it. And from what I can understand, the services that you've chosen to look at are used less often. And frankly, services such as physician office visits, which are used more often, are less likely to have a higher copay. So I think we have to look at the kinds of comparisons that are being made, and frankly, your plan, your proposal, your report looks at inpatient hospital and home health and ignores physician office visits, which 97% of beneficiaries experience, 8.5% experiencing home health and 25% experiencing inpatient hospital. It's my view that this report ignores reality. And I think if we're going to have a meaningful discussion, and I appreciate, Mr. Weems, your comments that you're going to get some actual data to us so that we can really have a meaningful discussion about this. So thank you for that. Thank you for your testimony as well. So I guess I think it's important that we get a report that is real, that we have an opportunity to review, so that we can have a meaningful discussion. I think this really is a fake report with fake conclusions, and we're having this fake hearing about it, so we can all run to the media and make certain pronouncements. I think health care is too important. I think our seniors are too important. I think the choices that they want to make are too important to conduct the people's business in this way. So, again, I'm going to send a letter to the Comptroller General. I look forward to his response as soon as possible. Thank you, Mr. Chairman.
Well, you're welcome. I'm sure that there will be others here who don't like the report, and I'll reserve my comment till a second round and ask Mr. Thompson if he'd like to.
Thank you, Mr. Chairman. Mr. Cosgrove, we've heard before in testimony before this committee in the past, and we heard it again today, that Medicare Advantage plans, especially private fee-for-service plans, are rapidly increasing in enrollment. And your testimony notes that the Medicare Advantage plans were originally envisioned as a potential source of savings. Is that correct?
That is correct. When what was once called the risk program started in the 1980s, yes.
Okay. Are they currently achieving savings for today's Medicare program?
No, absolutely not. According to the MedPAC analysis, the average plan bid for simply providing A and B services is 101% of fee-for-service. And on top of that, plans get rebates.
I'd like to talk about something that hadn't been brought up yet, and that's the impact that these plans are having. And if we don't do some sort of reform to the Medicare Advantage plans, we'll continue to have on Medicare's trust fund solvency. Can you speak to that at all?
As I mentioned in my statement, in 2006, for example, we paid an additional $7.1 billion extra to Medicare Advantage plans that would not have been paid if those beneficiaries had been in fee-for-service. It's true that beneficiaries in those plans did receive lower cost sharing and additional benefits, but there's not a free lunch that came out of the $7 billion.
And it's my understanding that the Medicare Advantage overpayments and rebates, had it not been for those, the Medicare trigger never would have been pulled. Can you comment on that at all?
I've heard that. I haven't looked at the numbers according to the Medicare actuary. It certainly has reduced the life of the HI trust fund, and it certainly has contributed to higher premiums for Part B for all beneficiaries.
And your report also found that plans are allocating 20% of their rebates, or $17 per month, on reducing premiums. However, you note that 41% of the beneficiaries are charged an additional premium for the privilege of participating in a Medicare Advantage plan, and that the additional premium averages about $58 per month. So at the end of the day, are the beneficiaries who are charged an additional premium actually seeing any savings on their premium cost?
Well, they're seeing, the average beneficiary is seeing savings overall, but not on the premium cost, no.
And how about in comparison to traditional Medicare?
I'm sorry, the question is?
The savings, the cost savings over beneficiaries in traditional Medicare.
Well, again, it depends on whether you're talking about the average beneficiary or some beneficiaries. The average beneficiary would see overall some cost savings, but there are beneficiaries in plans who could see higher expenses.
Mr. Weems?
Good morning, sir.
I'm perplexed that the budget, the administration budget, paid a lot of attention to Medicare spending and solvency, specifically in the areas where they tried to strengthen Medicare, such as cutting physician rates by over 10% or cutting hospital payments, billions of dollars, so severely, I might add, that in California, our hospitals alone would see a loss of over $800 million in 2009, and yet there's no mention of any payment reform for Medicare Advantage plans. GAO stated that these plans achieve no savings. CBO has stated that reforming the Medicare Advantage payment rates would improve trust fund solvency, and MedPAC has stated that there's no policy-based merit for these overpayments. Why do you think these plans deserve such special treatment when it's clear that they don't yield any special results? And if you guys aren't listening to the GAO and the CBO and MedPAC, which experts are you listening to when you develop your policy for the Medicare Advantage policies?
Thank you, Congressman. Medicare Advantage, at its heart, is about choice. You note the growth in private fee-for-service. That growth is in rural areas where the kinds of services and benefits that Medicare Advantage offers has not been available. As for our budget protects those kinds of choices, but goes directly to the kinds of solvency issues that you mentioned. If our budget were enacted, the solvency of the Part A trust fund would be extended by 10 years.
I would like to see your budget come to a vote of this full committee and to a vote of the full House, because I don't think there's 3 votes for it. You cannot tell me that if we cut by over 10% physician rates and decimate funding for hospitals, and those are hospitals that are also in rural areas, that somehow that's good for the people who need health care in not only rural areas but urban areas as well. And to the question of who you listen to, who you get your information from and developing these policies?
Congressman, we get information from a variety of sources, including the GAO, the Congressional Budget Office, outside groups.
And MedPAC?
And MedPAC.
And they've all said contrary to what your policies are proposing.
Those are financial analyses. The Congress, when it enacted this bill, made a policy choice about choice. And that, at its heart, is what Medicare Advantage is. It's about giving beneficiaries choices.
Thank you.
If the gentleman would yield, I believe, Mr. Weems, your own actuary said we're paying too much for Medicare Advantage.
Our own actuary would say that
He may not phrase it that way.
he would say that Medicare Advantage is paying above the fee-for-service rate. Yes, sir.
Okay.
Well done.
You're not going to fire him, huh? Mr. Becerra, would you like to inquire?
Thank you, Mr. Chairman. And thank you for coming to testify today. Let me see if I can ask Mr. Cosgrove to make something clear to me. The gentleman from Michigan, Mr. Camp, took umbrage to the fact that your report was based on projections and did not, in one instance, talk about the reality for one particular individual who receives his or her care through the Medicare program's Medicare Advantage system. And just to be clear, Medicare Advantage is an HMO type setting where through an insurance program, through an insurance company, a senior receives his or her care versus the senior receiving traditional Medicare, which is where the senior can go to any doctor or any hospital to receive the care because he or she is a Medicare beneficiary and can go anywhere he or she likes. If you go to the insurance company and that insurance company's system, you have to stay within that system and you accept that package that that system offers you. But again, Mr. Camp took offense that your report was based totally on hypotheticals, on projections.
Yes.
My understanding is you had no choice but to base it on hypotheticals and on projections because the law doesn't require CMS to talk about real people. And so therefore your analysis has to be based on what you get from CMS. Is that correct?
That's absolutely correct. Plans are not required to provide any data on what they actually spent or the benefits they actually provided. The only data that we have available are the data the plans submit annually, and that's in their bid proposals and their plan benefit packages.
And so, Mr. Cosgrove, your projections and analysis of these hypothetical patients under these Medicare Advantage plans that Mr. Camp took offense to are the actual projections, are based on the actual projections provided by the plans themselves to CMS.
Yes, that's true.
So our difficulty, and I agree with Mr. Camp, we should be talking about real people. Your problem is when the Congress in early 2000 or 2002 or so passed this law on Medicare Advantage under then Republican-controlled Congress, it did not require CMS to collect data on real people. In fact, CMS has no authority under statute to collect information on real people under the Medicare Advantage plans. Is that correct?
That's correct, and that contrasts with the situation in Medicaid, where many states contract with managed care plans and require those plans to provide data so that states can know whether their Medicaid beneficiaries are receiving preventive care and other services.
So I think all of us probably on this dais would agree with Mr. Camp that we should be talking about real people, which would require that the plans do what other medical programs that get government subsidies do, and that's to report on real people what their outcomes are. So I think it'll be fair to see fair to ask for that and then base some of our judgment on that. A few years ago, actually a number of years ago, we would constantly hear stories about the $300 or $400 or $500 toilet seat that the Department of Defense was buying for this or that plane or facility, how we were paying tens of dollars for a screw, and we just found that things weren't being done well and lots of waste in the Department of Defense. We're being told by the plans that they will do certain things with the money we're giving them, and including the rebate, which is above and beyond what a doctor or hospital would receive under traditional Medicare.
Right.
But we have no guarantee, as I think Mr. Camp pointed out, what in fact real people are getting from these plans. And so while it may not be the same as a $500 toilet seat, in many ways we can't determine if we're getting a $500 toilet seat or not out of some of these plans, can we?
That's absolutely correct. There is no way to determine that. I mean, we would certainly welcome the request from Mr. Camp, and we'd welcome the ability to get data from plans.
And I think it's important for us to get that information because many of us are in in some of these health plans or have family or friends who are in these health plans. My parents are in a Medicare Advantage plan in Kaiser. Mr. Stark mentioned Kaiser. In Sacramento, California, they have been in Kaiser. They enjoy having Kaiser as their provider. And so there are a lot of plans that are doing some great work. And so I think what we want to do is get the facts so that we don't disparage the good folks who are providing good services, and that way we can distinguish between those that aren't providing the best of services. My final question is this. I believe, was it, Dr. Williams, Mr. Williams, I think you mentioned that at the end, right before I started my questioning, that in fact the actuary for CMS has said that Medicare Advantage plans are receiving a greater reimbursement amount or a dollar amount than our traditional fee-for-service providers.
That's correct.
And I believe, Mr. Cosgrove, you said that totals $59 billion more that's going to Medicare Advantage than would go for the same services under a traditional Medicare service program.
No, that was total spending in 2006. The additional spending amounted to $7.1 billion in 1 year.
Okay, $7.1 billion. And so we're talking real money. Whatever the amount is, we're talking real money. And those are billions of dollars that we spent, taxpayers spent, to provide Medicare services to seniors. Not really sure how it was spent. In some cases, we think it was spent well. Other cases, we're wondering. But given that we're in this crisis and everyone's talking about how the sky is falling for health care and Medicare in particular, I think we do have to get the real numbers. So I think, Mr. Williams, we're looking forward to receiving that information. I think Mr. Camp's request is legitimate, and I hope we all join in requesting that information so that we can base our aim on the facts. So I thank the gentleman and the chairman for the time.
And before I recognize Mr. Pomeroy, I'd like to, Mr. Camp's carrying the whole other side of the dais here, and I'd like to yield to him for a few minutes.
I certainly appreciate it, Mr. Chair. I just wanted to comment. I didn't ask to be yielded to during your time, Mr. Becerra, but it's part of it that it's not just real people, but it's also the problem that it's only inpatient and home health. And those services that are used, more often, which are not included in this report, have a higher cost sharing. So I think it's not just the people, it's the focus of the report. I'd also like to see them include physician office visits and other portions, not just inpatient and home health. So thank you, Mr. Chairman.
Mr. Pomeroy, would you like to inquire?
Yes, Mr. Chairman, thank you. I have the greatest respect for the administrator. He's come to North Dakota. He's helped us with the hospital problem. Career man, ultimately, appropriately, on merit, advanced to the #1 slot, and I'm very pleased to smack. No, I'm very pleased with his leadership. It's a no-nonsense, get-it-done guy, and we know that representing the administration, he has to defend Medicare Advantage. What I want to focus on is what we're getting for the extra money we're paying. So, Mr. Administrator, you don't contest the $7 billion in extra payment as opposed to if we'd run those same benefits through Medicare, we paid $7 billion extra to have the insurance companies involved. Do you agree with GAO's comment on that?
That there are additional costs associated with the additional benefits and additional choice that right now Medicare Advantage plans are above the fee-for-service rate.
And because of the variety on the plans that are not fee-for-service, let's just talk about Medicare Advantage fee-for-service. It is generally believed that we're paying somewhere in the neighborhood of 12 to 17% more per dollar of benefit administered in order to have the private entity make that payment. Do you contest that?
It's not just the private entity make that payment. It's also the insurance value of the product that's being purchased by the individual by Medicare at that point. It's not just simply an administrative processing. For instance, a private fee-for-service plan offers, in some cases, for instance, a known co-payment for a doctor's visit. So a regular doctor's visit will say cost $20, not 20% or $10 or $5. So there's some the additional benefits may come in the certainty of cost sharing. The same way many of us have that certainty in our own private insurance that we have, rather than a percentage, which would now be the case for a Part
Although Medigap insurance has existed for decades that covers the unknown of the other coverages. And people can choose that if they care to. But as a system, we're paying 17% more to have the private insurance companies administer that benefit, and the rationale is it's about choice. Is that basically your position?
Again, with respect, I take issue with the administer the benefit. They offer additional benefits also, but yes, it is about choice. It is about offering these type products in areas which before they were not able to be offered.
I just take such issue with the administration's assessment of priorities within the Medicare program as reflected in their budget. I've got a whole page here of provider cuts, deep and painful provider cuts. The total in North Dakota would be devastating to the healthcare delivery system sustained across our rural reaches. You close a rural hospital, you've taken away choice. You drive physicians out of accepting Medicare because they're reimbursed so far below cost, they just don't want to do that anymore. And we're really believing we're about on the edge of that with some of our providers. You remove choice. So in my opinion, you really take a meat axe to provider payments. I agree with my colleague Mike Thompson when he says that there wouldn't be any support for this on either side of the aisle because of fear of that. But on the other hand, you don't take anything out of the overpayment to insurance companies that you acknowledge runs 12 to 17%. GAO tells us in 1 year we spent $7 billion just to the insurers. If Medicare administers the benefit, we're $7 billion better off in 1 year. $35 billion over 5 at that rate. And it would be a 5-year figure actually is going to be much larger than that because of the marketing growth of Medicare plans.
Absolutely.
And I want to focus on that growth in my final comments. We've been exchanging correspondence trying to get a handle on the consumer protection capability within CMS. You are aware, of course, that this choice that you defend it includes insurance agents making cold calls on the homes of senior citizens. Is that correct?
Yes.
There are not too many people I represent that choose to have that kind of visit. They just soon choose not to have that kind of visit. But what worries me most about it is you don't have much ability to oversee it, and you keep state regulators out of the picture. Do you see a resolution there of how are we going to get more consumer protection for the people that are getting the cold calls from the insurance companies paid 17% more for what they're doing than what Medicare does?
Thank you, and this is an important issue. No beneficiary should be deceived into accepting one of these products. And CMS has taken a number of steps and have a number of steps underway to prevent this. First of all, beginning in September, we built a rather substantial surveillance system. And as you may know and others may know, we spent a lot of time and effort doing secret shopping and actually sitting in the marketing campaigns. I sat in them in rural areas and in urban areas with a baseball cap on. They didn't know who I was. And immediately after those marketing campaigns, if there was a violation, we fed that right back to the plan. In some cases, we sanctioned them, and we saw a steady reduction in the amount of complaints. We're not done yet. We have some additional actions that we're going to take in the very near future that deal with exactly the same kinds of things that you're concerned about. How an insurance company makes contact with a beneficiary, what their commission structure looks like, and then also clarifying some of our civil and monetary penalties.
Just saying, I know my time is up. I mean, I used to do this for a living. I was an insurance commissioner. I wrote the Medicare standards that are now in place through the states as we enforce Medigap sales. To me, what you're describing is very, kind of happenstance. It's not a comprehensive regulatory system. The protections that you just described are available in state insurance department and in state law, and I believe this administration ought to advance. I mean, for one thing, we try to get you more resources. The president vetoes the bill. So you don't have enough resources internally. I believe you need to work with state insurance departments, and I'd like to see more from CMS in terms of working arrangements there. My time has expired, Mr. Chairman. Thank you.
Thank you.
Thank you, Mr. Chairman.
Go ahead, Mr.
I've heard of being in the minority before, but this is something
Had a
new for
lonely
me.
day today.
So thank you for that. Yeah. Mr. Weems, I just wanted to say that I've heard some reports about some of the unacceptable behavior by agents and brokers who are selling some types of Medicare Advantage plans, and I think there's bipartisan agreement these activities need to be stopped. What are you and CMS doing or going to do to stop this and protect beneficiaries from these kinds of individuals and plans?
Well, beginning in September, as I said, we built a rather substantial surveillance system, which included not only the secret shopper program, but also a system of calling beneficiaries. Did you know you signed up for a plan? Do you know exactly what you signed up for, to ensure that beneficiaries understand the choices that they're making? We also made it very, very clear to insurance companies that we're not going to tolerate this kind of abuse. In fact, one company, we had them suspend enrollment and marketing for the entire period of enrollment and marketing because there were systematic errors in the way that they were marketing the product, and it was completely unacceptable. And there are still additional steps that we're going to take in the areas of the way that the commission structure works. Beneficiaries should not be churned year to year. In the way that that insurance companies come into contact with the beneficiary, and then lastly, clarifying our own ability to level civil and monetary penalties.
Also, if you could comment, thank you for that answer. By purchasing a Medicare Advantage plan with a cap on cost sharing, can beneficiaries protect themselves against catastrophic costs? And isn't that what insurance is about, is protecting yourself against something that you think might happen but may not necessarily happen?
Absolutely. And in fact, that's what this chart demonstrates, is that beneficiaries can make choices about where they would like to protect themselves. Even at the very, very long stays that we have on here, you ask yourself, well, what's the probability of that? What would cause that? Well, our experts say that, yes, there are some of those very long stays, and the things that cause them are substantial comorbidities. You're a very, very ill individual. But even being very, very ill, using a Medicare Advantage program, you can protect yourself from some very substantial out-of-pocket costs.
Well, and I think nearly half of Medicare Advantage beneficiaries are in plans that cap their out-of-pocket costs. And is that something that's available in traditional Medicare?
No.
The ability to cap catastrophic health care costs?
No, it is not available in traditional Medicare.
All right. Thank you. Thank you very much for your indulgence, Mr. Chairman. I appreciate it.
Mr. Kine, would you like to inquire?
Thank you, Mr. Chairman, and I want to thank the witnesses for your testimony today. This is just an incredibly important issue back home, and Mr. Weems, I know you cited La Crosse, Wisconsin, which is in the heart of my congressional district in western Wisconsin, to make a point on, right, I agree, to make a point on some of the regional differences in payments, and you compared it with Dade County, Florida. But when you talk to the providers in western Wisconsin, they are always extremely frustrated that they're receiving, in their view, a lower reimbursement rate. And part of that is based on the efficiency and lower utilization that's taking place there. Yet study after study after study shows high quality of outcomes in the care that seniors are receiving under traditional fee-for-service. And so I'm not quite sure the regional differentiation that you're making in your testimony really applies all that well. It seems to be you're saying, listen, you got to look at the regional price differences in order to explain the overpayments for MA plans today, and you use La Crosse as an example. And in order to entice private plans to come into that area, in essence, you have to bribe them above what the fee-for-service providers are getting in reimbursements. And I'm not sure that's a real accurate apple-to-apple comparison to make under the circumstances. My question is, and maybe Mr. Cosgrove, since you're the one releasing the study today, is what's been frustrating with the MA plans is the lack of hard data that we have access to. Is there any way that you can get your hands on quality of outcomes or performance space with what the MA plans are providing with seniors today?
There's relatively little information available on that. Certainly, under Medicare Advantage, plans do have to submit some things, and I think Mr. Weems mentioned in his testimony in terms of satisfaction surveys, and there's a health outcome survey that cover part of beneficiaries. Those tend to measure very narrow things and not the basic quality.
What about utilization data? Can we get any information at all from the myriad of MA plans out there on what utilization is taking place?
I'm sure MA plans have it. As you know, that the plans that serve rural areas tend to be the private fee-for-service plans. Right. These plans pay claims just like the traditional program does, and so they certainly would have the data. They just don't have to submit any of that.
And that's the rub, isn't it? I mean, that's really the crux of the problem here, is that they don't submit it. Yet CMS, and I think Mr. Weems, you're saying in your testimony that in 2008, MA plans will offer, on average, over $1,100 in additional annual value to seniors that they cannot get under fee-for-service in the form of cost savings and added benefits.
Right.
But if we can't get utilization data, if we don't know what type of services are being provided, how can you define value? How can you make that claim that it's $1,100 of additional value if we're not getting the basic data that we need in order to calculate the cost?
Congressman, we're not completely blind to the utilization. It's in the bid tools. We do audit plans. We do have some sense of this. Nonetheless, I made a commitment today to the chairman to provide utilization information on the extra benefits, and to do that in an expedited way. And we'll have a discussion about the facts.
Well, that would be helpful. But I was astounded to hear your response to Mr. Thompson's earlier question when he was asking, what is CMS basing their defense and justification of these MA plans if you're going to choose to ignore GAO information, choose to ignore CBO information, choose to ignore MedPAC information, and your response was, well, it's all about choice. That's a philosophy, but it's not based on hard data. And that's really what I think we're grappling to get our hands on right now, is these reporting requirements that should be in place, so we can go into these plans and find out what's being offered, where are the true cost savings, if any, to the customers, what's the value that they're receiving, the utilization that's taking place. And ultimately, I believe that we've got to move to an outcomes-based type of reimbursement system as quickly as possible, so we're rewarding the outcomes, the quality of services being provided, and also the efficiency in which it's being provided. And we're not getting that from the MA plans. Choice is great in the theoretical world, but when you've got a 70-year-old senior having to compare plans, over 70 different plans in the state of Wisconsin that are continually shifting on them, whether it's co-pays or premiums, they're not the ones wrapping their arms about this whole choice philosophy. It's incredibly complicated. They're subject to marketing tactics that are unfair and is taking advantage to them, and we need to tighten this up. And it's also astounding to me that we have an administration willing to take a whack in their proposed budget with the providers across the country, and they don't look for $1 of savings with these MA plans in the budget that was just sent up. And Mr. Camp, I congratulate you for at least sitting here during this hearing. Where's the rest of the dais on your side? We're having, I think, a very important hearing on the state of MA plans, and yet there's no one on the Republican side other than yourself showing up to question the validity of it and whether the taxpayers are getting our dollars worth through these plans. And yet, over $170 billion of proposed cuts with healthcare providers. Well, and I know he's campaigning hard.
One of them's running for Senate in Wisconsin. You better watch your step.
That's right. That's right. But I'm only reflecting the frustration that I'm hearing back home from the providers, from the seniors, those who are in the plans right now. And for us as policymakers, when we're trying to make some policy determinations and we lack the hard data that I think is necessary. So hopefully with CMS's cooperation, we're going to be able to do a better job in the future. Thank you, Mr. Chairman.
I'd like to recognize Mr. Emanuel, and if I could get our witnesses, we'll have a couple of votes at about 11:15. We'll come back after those votes and allow the other members to inquire. If I can presume on the witnesses to stick around for a few minutes while we vote.
Please,
Mr. Emanuel?
Yeah, I'll try to be quick so maybe one of the colleagues can get in before the votes are called. I didn't expect you guys or anybody in the audience to see this, but the other day we had a debate among 4 Democrats, 4 Republicans over at George Washington University. And the congressman, Mr. Chairman, that you referred to from Wisconsin, did acknowledge at the debate that he would take seriously, and look, I think I'm quoting him accurately. Paul said this, that in fact, that he would look seriously at that we shouldn't be paying 120, 125% of fee for service, as long as it didn't go into expanding coverage, but dealt with the shortfall in Medicare. And it was, when you get out of here and get out of posturing, he was honest about you shouldn't be paying 120%. I mean, there's a reason this is called Medicare Advantage. It's a real advantage for the HMOs. There's just no doubt about it. And this is this is an ideology trumping good judgment. Everybody always tells us government should do what business does. So here you got a case where you could save on money, but we're supposed to pay 120%. Now, I happen to have been there in the 90s in the White House when the HMO said they could deliver it for 95% of fee-for-service because they could do a better job of managing costs. So we're getting the same service now for 120% of fee-for-service. There were some mistakes made in the 90s, no doubt. But the notion that we're going to try to figure out how to deal with the trust fund, but something everybody independent analyzed says that could save $50 billion over 5 years, $150 billion over 10 years, that's off the table. You're never going to get an honest discussion of everybody putting some skin in the game and putting something on the table. You cannot have a serious discussion about Medicare's trust fund if one of the elephant in the room is not going to be discussed. And it's not the only elephant. We got to look honestly at how we pay fee for service, whether there should be more flexibility. Some of the things the administration has pointed to are worth looking at. They're not going to be wholesale thrown out. But the notion that this big item that you're overpaying for can't be looked at on the start means that you're never going to have a serious discussion, and it's just going to be political. And at some point, ideology cannot trump good judgment. It just can't. And if you did it all on HMO, Peter Orszag and others have acknowledged it add 3 years to the trust fund. 3 years. I'm not saying that it has to, carry the whole burden here. But the notion that you would start off by saying this can't be part of any solution, it's ridiculous. It doesn't hold up. And people know it. And that means every other good recommendation from the administration won't be considered. You've tainted it. Because you basically have said ideology and politics and partisanship trump getting a good judgment and a good result. And that's unfortunate for all the other good decisions you've made and some of the recommendations, because they won't get a fair hearing. And you hurt yourself that way. Second is, as Orszag testified in this committee the other day, we don't know what's in these plans and what we're getting our money's worth. It's just like a blank check. Something my kids would like to have. We wouldn't do that. And you can't keep treating taxpayers as dumb money. You can't ask them to pay 120% what you know you can get for 100%. I spent a short time on Wall Street, and when people would make investments like that, you'd call them dumb money. So my recommendation is, let's everybody put their cards on the table. There are good recommendations in the administration's proposal that are worth looking at. But if you start off by saying, we won't look at this, and that's an absolute, that means every other judgment you've made won't get a fair hearing, and you've hurt the cause of trying to look at what does it take to deal with the Medicare trust fund insolvency. Thank you, Mr. Chairman. I hope I've left some time for my colleagues.
Schwartz, would you like to inquire?
Yes, thank you, Mr. Chairman. I really appreciate your courtesy in allowing me to ask a question or two. And I appreciate following up on my colleagues. I mean, I think they've made it very clear, and I agree with them, that we are taxpayers, and actually 80% of beneficiaries under Medicare are paying more in order to give 20% of Medicare beneficiaries choice. You made that very clear. The issue is we don't really know that they're getting more services. Right? You can't tell us that. You can't really tell us whether they're actually having any improved outcomes. We have no idea. You're going to try and get us that data. That would be useful. But you made the point was made that maybe, and Mr. Camp said this, that maybe we really haven't looked at real people here. You know, that maybe real people are getting benefits, and we just don't know it, but they're getting some additional benefits. They're happier because they have choice. I think when we're talking about health care, we ought to make sure that they're healthier also. But I want to talk about a particular experience in southeastern Pennsylvania in my district. One of the things that we have seen in the last year is really an incredible growth in the Medicare Advantage fee-for-service. That's been the strongest growing effort. I know the discussion was it was supposed to really be in rural areas. I don't represent a rural area. It's an urban suburban area. We have seen an increase we went actually from, in Pennsylvania totally, 24,000 in just the fee-for-service plan to almost 50,000 people in the last year. In my own district, we've gone from 1,000 to almost 4,000 beneficiaries. Now, if you can say that they're actually getting more services, they're healthier, maybe we would be able to feel better about this. But what I want to tell you is that 3 of the major hospital systems in the Philadelphia area have decided to no longer accept the Medicare Advantage fee-for-service patients. So theoretically, you're expanding choice. In fact, as was pointed out, we're seeing a denial of fewer hospitals taking it. These are not just hospitals, they're really these health systems. And they say the reason that they're doing that are manifold, but one of the principal reasons is that the beneficiaries and the providers do not know when they refer to physicians whether in fact those physicians will be covered. So they don't know. They have no way of getting that information. The beneficiaries don't, the hospitals don't. So they make referrals, and they have no idea whether this is going to be an appropriate referral or not. They may show up at that physician's office, get the services, and have to pay 100% out of pocket. So I ask this question because we are paying 20% more on average for these patients.
No.
Well, I can tell you, in Pennsylvania, the fee-for-service plan in my district are paid on average 18% more than it costs to provide exactly the same services to Medicare beneficiaries. That's the numbers we have. This is in southeastern Pennsylvania in my district. So we're paying 18% more, and people are going to see less care. They're seeing it already. And they are actually not getting the information to be able to make choices, and nor are their providers. So this seems to me not just a bad idea, a disaster. So how do you defend that? How can you justify that as either good public policy or good health care, good outcomes, or anything that's positive, and some way we're going to fix this?
Thank you for the question. The first thing is we know that I'd have to look at the private fee-for-service area programs in your area. For the most part, many provide protection against very high out-of-pocket costs. That's a protection that people get as a matter of insurance. Now, it is true that providers don't have to accept private fee-for-service. And if it turns out that providers in that area aren't doing that, then people are going to leave those programs and go into products that are going to be much better for them. The plans have considerable outreach into the community.
So how quickly can they make that change? Not quickly. Next year.
Next year.
Right. So for a year, they may actually have no access to care.
Not no access to care.
Possibly, if the hospital and the providers are not accepting it. They're stuck in a plan that has higher costs and no access to care. But they have choice.
Wouldn't suggest that it's even higher cost. They may be in a plan that has lower costs, and they
But
go
it's
to lower
theoretically
cost
possible
provider.
they're in a higher cost.
Many things are
If they
theoretical.
need more outpatient, for example, than hospital care, it could be higher cost for them during that cost of the year, and they could not change for a year.
Depending on which plan they chose. That's the nature of insurance, yes.
Well, maybe it is a very different ideology to say that we are moving this to a private insurance model rather than one where we are looking at for seniors, and we've said to seniors under Medicare that we're going to help ensure that they have access to health care. We'd like to be quality health care. We'd like to be cost efficient, right? And we think the taxpayers shouldn't have to pay more for less. But you're saying as long as they have choices, if they've made a bad choice, too bad. It's an insurance model.
Well, in many cases, the regular Medicare program may not be their best choice.
It may not be, but
And in which case, it's just too bad there, too.
Well, and I'll give back to the chairman, but the idea here is not to say I don't think any of us are saying let's limit this to one option. We've never said that. We've talked about 11 Medigap plans. We've talked about the fact that even under Medicare Advantage, if we were paying the same and getting more benefits and people were getting better outcomes, it may even be worth paying more, although I think there's a lack of justification for why just some people should get that and not all. But we're not talking about an either-or here. We're talking about better oversight, accountability, right? Knowing what we're doing, making sure we're getting what we should for our taxpayer dollars, and that Medicare recipients are not actually disadvantaged by this rather than advantaged. So it's simply not good enough to say, wait a minute, if we ask hard questions, you're going to say, well, then we won't do any of it? That is not an acceptable
If you are talking about reducing the payments, you are talking about an either-or situation in many parts of this country.
I want to try, if the gentlelady will yield, to let Dr. McDermott inquire.
Thank you, Mr. Chairman, and thank you for your indulgence.
Before the votes bring down.
Thank you. Thank you, Mr. Chairman. I appreciate your taking time. And I just have a couple of questions. My understanding from your report is that Medical Advantage has a loss ratio of average of 80%. Is that 87%? Is that correct?
That's correct. Yes.
And on the other hand, Medicare has a loss ratio of 98%. That is 2% is going for administration, 98% going for benefits.
According to the trustees, yes.
According to the trustees. You trust the trustees?
Absolutely.
So where does this 11% go? Is it, or where does it come from? Or how does it occur? I mean, we're paying insurance companies and they're giving less care. They're taking 11% somewhere. Where does it go?
Well, plans obviously have expenses that the traditional program doesn't have. Marketing
like what?
expenses.
I mean, what is the benefit to the patient for those costs?
Well, marketing expenses would be, but that's not a benefit to the patient.
Well, my mother's now dead, but I used to get about one a month of an advertising campaign from somebody, which I don't think did much for a 96-year-old woman. No. I really think the thing that really puzzles me is that a third of those plans, as I understand it, have loss ratios less than 85%.
That's correct.
Can you give us the names of those?
In discussions with CMS obviously considers these data proprietary and very sensitive. So,
but this is taxpayer money. What do you mean proprietary? You mean the Congress can't know who's ripping old people off? We can't look at the data? Is that what you're telling us?
Mr. Weems has the data, and it would be up to him to share it.
It's up to CMS today to give it to us. Is that right?
They're the owners of the data. They shared it with GAO, and they gave it to us with some restrictions as to how we could report it.
And on what basis, then, Mr. Means, how do you hold this data back?
These data are proprietary and may affect the competitive nature of the firms.
Is there any reason we couldn't see them in camera?
I believe we could make it available under those circumstances, sir.
You believe we could?
I think we should.
Is that a yes or a no?
It probably is a yes.
Yes. The answer is yes.
So we got an actual yes out of you. I think, Mr.
But you can't talk about it now.
It's secret. That's right. Then we'd be liable for suit. Is that right? If we talked about the data?
I'm not an attorney. I couldn't say.
See, the problem here is...
If you gave it to the New York Times, maybe you would.
I know some guys at the New York Times. The fact is that I admit I'm a single-payer advocate. I believe that a single-payer system like Medicare is the way to go. And you're not giving me any reason. Mr. Kine asked on the basis of outcomes, which is what healthcare is supposed to be about. If you have healthcare, you're supposed to live longer than people who don't have outcomes. So we have this medical advantage. We pay them all this extra money. They should be getting better outcomes. But you have no data to prove that. All you have is 11% that's going into marketing and profits for insurance companies, I guess. I don't know where else it's going.
Through HEDIS data, Congressman, through HEDIS data, we do have outcome data, data that we don't have for the fee-for-service side.
And can you share that data with us?
Of course we can. Absolutely.
That's not proprietary.
No.
I think the committee ought to be provided, Mr. Chairman, with that information so that we can actually look at the proof that the Medical Advantage program does any good for the health of senior citizens. Because that's what this is really all about.
Absolutely.
It's not about choice, and it's not. My mother didn't want choice at 97. She just wanted to know she could call up the doctor and go see him when she was sick.
Would the gentleman yield at that?
Yes.
If you leave out dollars, copays, I don't think, and I'd ask Mr. Wee, I don't think there's a plan in the country that has more choice of physicians and hospitals than Medicare. How many hospitals do you know that aren't in Medicare?
Very few.
How many doctors are not in Medicare? Not many. So, I mean, when you talk choice...
Well, that's one kind of choice, yeah.
Yes, it is, but it's
the only choice that matters, Mr. Chairman.
And if now, they may be...
Catastrophic costs matter, too.
They may be limited by cost. That's a question, certainly. But on the other hand, some of the plans limit them by not recognizing the doctor, not having the doctor in the plan. So I would, in defending the plan that Mr. Weems runs so well, called Medicare.
Yeah, we like that one.
I'd like to point out that he offers, 80% of us Medicare beneficiaries broad choice.
Well, we offer it to one.
Thank you very much for that.
We offer it to 100%. 80% take us up on the offer.
Okay.
Both Mr. Stark and I are taking you up on it, and we enjoy it.
I want to thank...
We like part of
you.
you.
Stay here after the vote ends, Doctor, but I'm going to thank both Mr. Cosgrave and Mr. Weems for their patience, their indulgence, their forthcoming testimony. We'll have you back. I want to discuss this some more, and we'll excuse you, gentlemen, and thank you very much. We'll recess for approximately 15 minutes till we finish these votes, and if the second panel wants to come on up to the witness table or get a cup of coffee, we'll be back and continue the hearing. Thank you.